All right, I think everybody's here. Good afternoon, everyone. I hope everyone had a really great Thanksgiving. Okay, so today here's the game plan for this week and next week. So today I'm going to be giving three lectures and I'll give it consecutively, breaks 23, 24, and 25. The protein S, protein C, the coagulopathies, and also two. The title of the other one is vitamin K. Vitamin K metabolisms. Vitamin K metabolism. That's really important. Okay, so what's going to happen is that tomorrow you'll be getting two quizzes. And instead of getting your full exam 5, you'll just be getting the matching portion of the exam 5. And I'll talk about the matching portion. I think the matching portion shouldn't be too bad. I think you guys like matching. You do. The class does pretty well on the matching. And then next week, you'll be getting, I won't be lecturing, but then I'm going to be giving to Xavier your lecture 5 multiple choice portion of exam 5. Okay, and it's going to be over 60 questions. I'm going to be sending you the reviewer for that multiple choice exam. And then in addition to the multiple choice exam, you're going to be asked to map out the pathways, the fibrinolytic pathway, and the coagulation cascade. Both of those will be pretty much blank pages, but I did send you the word banks, examples of the word banks that I'll be given to you. So all it will be all you have to do is just a matter of arranging all the factors and all the enzymes and activators and inhibitors in the correct place for the fibrinolytic pathway and for the coagulation pathway. Also, too, I also sent to you, and I'm going to go over after my lectures, the coagulation cascade, because I added on some important cofactors like pre-kallikrein going to kallikrein, the high molecular weight kininogen, and also to the 6 reactions where calcium takes part. Okay, I don't know if you opened up that file yet, but we're going to go over that as at the end of my lecture. So I'm going to go over the coagulation cascade. The fibrinolytic pathway you should know, especially please memorize the inhibitors and the activators. And also to make sure you map it out, starting with plasminogen, going to plasmin, going to the scissors, the fibrin being chopped up. Okay, make sure you memorize that, and I'll show that to you later. And then also too, we'll go over the factor deficiency table. I know that's a huge table. I'm going to go over it with you and show you some tips on how to memorize the reactions for the various factor deficiencies. Okay, so to start off, we're going to go over protein S and protein C. Okay, starting with protein C, it's a major physiological anticoagulant. So if you think about anticoagulant, remember the coagulation cascade. If something's missing in that cascade, you won't get a clot. Therefore, it's an anticoagulant. So something has to be missing to prevent it from forming a clot, and that's protein C or activated protein C. So something's missing, and we'll find out what that is. It's a vitamin K dependent factor. The role of protein C is as an anticoagulant. Remember, with respect to the coagulation cascade, no clot is formed. And it's related to the presence of 3 things: thrombin, thrombomodulin, and protein S. Okay, so thrombomodulin is found in the endothelial cell membrane glycoprotein that forms a 1-to-1 complex. It'll bind with thrombin. And as you recall, thrombin is when you got prothrombin, the thrombin, and thrombin branches out. If you recall, on the right side, it's 13 going to 13A, and then on the left side, it's fibrinogen going to fibrin. But thrombomodulin will bind to thrombin, okay? And that complex is important. Thrombin escapes from the site of injury and binds to thrombomodulin. That's what will happen. That's how thrombomodulin finds the thrombin. It'll form that 1-to-1 complex. Thrombin has proteolytic activity to convert fibrinogen to fibrin. So without thrombin, then fibrinogen will not form fibrin. So that's one of the anticoagulant activities, because fibrinogen will not be converted to fibrin, because thrombin has now bound to thrombomodulin. Okay, once thrombomodulin forms this complex with thrombin, when thrombomodulin forms the complex, fibrinogen will not convert to fibrin. That's what I just said. Okay, because thrombin is not available to catalyze that reaction, if you recall from coagulation cascade. So this complex, this thrombomodulin thrombin complex, will convert protein C to activated protein C. Protein C is one of those factors. It's an anticoagulant that circulates in your blood system, and it'll convert. So you know how you have your 12, 11, 9, 10? Remember those four numbers when you do your coagulation cascade. You start off 12, 11, 9, 10, and it converts to 12A, 11A, 9A, and 10A. Okay, the coagulation cascade, you should be very, very familiar with that. Well, anyway, this complex, this thrombomodulin thrombin complex, will convert protein C to activated protein C, APC. Again, these are it still has anticoagulant capabilities. So activated protein C dampens coagulation by cleaving 5A and 8A. So now you have two places in the coagulation cascade where components are taken out. The first one is, remember, is thrombin, to prevent fibrinogen going to fibrin. And this is the second place. It'll cleave 5A and 8A. So it has two places in the coagulation cascade where components of that cascade is taken out. So as you know, when you draw blood into EDTA, sodium citrate, et cetera, calcium is taken out. Well, with protein C, or with the thrombomodulin thrombin complex, you're taking out thrombin, and then you're also taking out, you're also cleaving 5A and 8A. Okay, so those are reasons why this protein C is an anticoagulant. The rate of thrombin formation is slowed, obviously, because thrombin is being taken out, and APC is a circulating anticoagulant. It's a circulating anticoagulant because the end product of the coagulation cascade is a clot. So APC is a circulating anticoagulant. Protein S, because protein C and protein S go hand in hand, the inhibition or cleavage of 5A and 8A by protein C is enhanced by the presence of protein S. So protein S basically is a cofactor. It just helps out, and it piggybacks on top of protein C. It doesn't really, there's a reaction that takes place that is important, and it's good cosmetically, but protein C just piggybacks on top of what protein S does. And protein S will cleave the 5A, and I'll show that out. I'll show that to you in an illustration later on. So the role of APC, the activated protein C, is to turn off the amplification pathway of thrombin generation. I mentioned that early on. So it's an antithrombotic, this is antithrombotic activity, okay? So APC also has anti-inflammatory properties. So this is good because you know how damaging and inflammation can affect your body. There's chemotaxis going on. It releases anti-inflammatory response in leukocytes as well as endothelial cells. It reduces the cytokine response. Leukocyte adhesion is decreased with APC, and it reduces the infiltration of leukocytes. So all of those are pretty aggressive actions that your body takes. You know, the chemotaxis, the leukocyte adhesion, and the infiltration of leukocytes. Well, what APC does, it's not going to inhibit the inflammatory response, but it'll just tone it down. Okay, it reduces chemotaxis. Chemotaxis has to take place, but it'll reduce it. Cytokines have to take place, but it'll reduce it. You need to have infiltration of leukocytes, but it'll reduce it. Okay, so, and you also have to have leukocyte adhesion. APC just tones down the inflammatory response. APC supports endothelial barrier functions. So now we're getting into the functions, if you recall, the inflammatory response with the barrier function. It also provides protection of endothelial barrier function. The endothelial barrier breakdown and the corresponding increase in endothelial permeability. Remember the endothelial permeability at the diapedesis are associated with swelling, hypotension, and inflammation, all problems of sepsis. So protein C, again, will tone down the inflammatory response. It's not going to inhibit it, but it'll just slow it down. It'll reduce the action. You also recall apoptosis. Apoptosis, as you recall, is the natural process of programmed cell death. Okay, so you remember in the leukemia lectures, apoptosis takes place, but in the presence of an oncogene. An oncogene will approach a cell that is programmed for dying, and what it'll do is it'll convert that cell that's programmed for dying and turn it into a cancer cell. And then the opposite of that, to prevent that oncogene from doing that to a dying cell, you have a tumor suppressor gene. Okay, so in terms of protein C, apoptosis will take place. And then, but activated protein C is not going to turn these dying cells into zombies or leukemia cells like they did in the leukemia lectures, because activated protein C has anti-apoptotic effects. So APC has neuroprotective properties, and its anti-apoptotic effects makes it useful in the treatment of sepsis. So when you have dying cells or cells that are cause necrosis, for example, what APC does, it'll prevent the breakdown of tissue and the breakdown of cells, and it'll slow down cell death, not necessarily to form those zombie cells, those zombie leukemia cells, but it'll make the dying process a little bit more smoother, and it'll just slow down cell death. And actually it has, APC has some good cosmetic effects as well too. There's the coagulation cascade. You should be very familiar with that. And when I ask you to do the cascade, you don't have to use the Roman numerals, okay? And we're going to go over this again after my lectures. Okay, so protein C. Okay, so what I just talked about was protein C and its anticoagulant properties. Well, if you don't have protein C, or if you have a protein C deficiency, so you'll get the exact opposite. Rather than anticoagulant, you're going to have what's called hypercoagulability, or you will have the tendency to form clots. Not necessarily DIC, but you won't have the anticoagulant effects of protein C anymore, but you'll have the increased tendency to form clots. So with protein C deficiencies, what happens is you'll have a tendency to form venous thrombosis, remember the varicose veins, and also to habitual abortion. And protein C deficiency in the homozygous state, and when you deliver a baby in the homozygous state, you'll have DIC in newborns. And that condition where you have DIC in newborns is purpura fulminans. So this is due to a protein C deficiency homozygous, and it'll result in DIC in newborns. You already know how bad DIC can be from the DIC lecture. And the way to treat this is to replace the defective or deficient protein C. Okay, so, and then you find out if you're deficient in protein C in the prenatal testing. So if you're lacking in protein C, that's a cause for concern, because if you lack protein C in the homozygous state, for example, then you can get this purpura fulminans. So you replace the bad or missing protein C. Another name for purpura fulminans is purpura gangrenosa. It's a hemorrhagic condition, and it's associated with sepsis or previous infection. And this occurs in babies and small children. It's a protein C deficiency. Purpura fulminans clinical manifestations, it's acute onset, cutaneous hemorrhage in skin, tissue necrosis. Again, you know, you have tissue necrosis, you don't have protein C to help you out cosmetically. You have low blood pressure, fever, and DIC. The cause of purpura fulminans is severe infection, especially meningococcus and gram-negative organisms. Also, too, you'll have a deficiency in natural anticoagulants. Obviously, protein C deficiency, you lack the anticoagulants protein C and protein S. Okay, so you don't have the anticoagulants. The opposite of anticoagulants is hypercoagulability, and we're going to get into this. So with protein S around, you're not going to form a clot, therefore anticoagulant. If you lack the protein C, then you're going to have a hypercoagulability where you are going to have a tendency to form clots. And another cause of protein C is listed as unknown. The treatment for purpura fulminans is to remove the underlying cause. Like, for example, if you're septic and you have bacterial sepsis, then you have to treat the infection. Suppurative therapy, and in drastic cases, your digits may be amputated when the blood supply ceases to flow. So activated protein C, okay, as you know, will cleave factor V in its ability to cleave factor V. But if that ability to cleave factor 5A or 8A is defective, you'll have activated protein C, but it doesn't work. It's not cleaving the 5 or 5A. So rather than being an anticoagulant, again, the opposite of anticoagulant is hypercoagulability. You'll have an increased tendency to form a clot, okay? So keep that in mind. Protein C will take out 5A and 8A, but when it's defective, 5A and 8A are intact, therefore you will form clots. But in this case, if the activated protein C is defective, you have what's called activated protein C resistance. Okay, again, hypercoagulability. So with activated protein C resistance, this condition can be hereditary or acquired. The hereditary form is what's called factor V Leiden, and it's a condition, it's a hypercoagulability condition, and it's significant in women. The acquired forms occur in the presence of elevated factor VIII. So you can have elevated factor VIII, and that can also cause you to have activated protein C resistance. So if you just have elevated factor VIII, that's the acquired form. The hereditary form is factor V Leiden. Warfarin necrosis. Okay, so you know what warfarin does? Warfarin is the same as Coumadin, activates, you know, the external pathway, factor VII. Cause for active is another reason for acquired protein C deficiency, and it's caused by the treatment of warfarin, a vitamin K inhibitor. So initially, so if you're on warfarin, you're going to get your 27910 inhibited. But also too, if you're deficient in protein C, the inhibition of protein C is stronger. So that will lead to the activation of coagulation and necrosis in skin areas. You're going to get the anticoagulant properties with the vitamin K and the warfarin, that's true. But with the protein C deficiency, that will supersede the anticoagulant effects of your warfarin. Okay, so the inhibition of protein C with an acquired protein C deficiency will take over, and that's where you will have activated coagulation and necrosis in skin areas. Going back to the factor V Leiden. So factor V Leiden is a variant of human factor V that causes hypercoagulability disorder. So it's almost like DIC, but it's not. You're forming clots, but you're not forming clots systemically. Okay, so you can get like varicose veins, etc. It's a hypercoagulability. You'll have a tendency to form a clot. It cannot be activated by factor V Leiden cannot be inactivated by activated protein C as a treatment. Okay, the most common factor V Leiden is the most common hereditary coagulability disorder among Eurasians in Europe. And it was named after a city, the city Leiden in the Netherlands, and first identified in 1994 by a Professor R. Bertina. And there's the Netherlands and another shot of the Netherlands. Really really beautiful city if you've ever been there. Okay, so studies have shown that a high correlation between factor V Leiden and the risk of stroke from hormone therapy patients. So again, think of the factor V Leiden as a hypercoagulability condition. So now that you're forming clots, you have now the risk of stroke from hormone therapy patients. So women taking birth control with factor V Leiden have a 400 times greater risk of getting a stroke. Women also have an increased risk of miscarriage and stillbirth if you have the factor V Leiden condition. So excessive factor V Leiden, you have excessive clotting, okay? Excessive clotting, again, hypercoagulability condition. So it's restricted to the veins. You may cause deep vein thrombosis. Remember the varicose veins. And when the clot breaks off, it's just like, if you remember that recall that with the varicose veins, if the clot breaks off from the varicose veins, it'll travel to the right side of the heart and lung and result in pulmonary embolism. And it can also cause stroke as well. So factor V Leiden, any Caucasian below the age of 45 with a family history of venous thrombosis should be suspected of factor V Leiden as a cause for any thrombotic event. So they need to be actively screened. At-risk patients should be screened with either the snake venom, dilute Russell viper venom, or an APTT test. In this slide, I'm going to quickly skim over. So the incidence of factor V Leiden is not so common in North America, only 5% of Caucasians. It's less common in Hispanics and African Americans, and it's extremely rare in Asians. To treat the factor V Leiden is a medication called Trecogen alpha, and it's recombinant activated protein C. So you're replacing the protein C deficiency or deficiency with this medication called Trecogen alpha, and it's used in the treatment of severe sepsis and septic shock and DIC. So that's the treatment for protein activated the factor V Leiden. Protein S, as I had mentioned earlier, protein S just tags along the protein C. Protein S is vitamin K dependent. It's made in the endothelium and exists in two forms, free form and complex form, bound to complement C4b. This is protein S. It doesn't really have that significant of a function, but it does have a function. It's a cofactor for protein C in the inactivation of factors 5A and 8A, and only the free form of protein S has cofactor ability. So what happens is, so here's your factor V and here's your other clotting factors, and here's the blood clot. Okay, so when activated protein C, here's factor V again, and this is activated protein C, and here's protein S. Basically, this protein S is just tagging along the activated protein C. But this activated protein C will bind to factor V and cleave it. And then remember, no factor, no clot. So factor V is gone, it's cleaved, you're not going to form a clot. So that's the activated protein C. That's what it does. Factor 5A is gone. And protein S, basically, as you can see, doesn't really do much. It's just attached to the protein C. Okay, factor V, activated protein C binds to 5A, and the 5A gets cleaved, and protein S does nothing, just takes credit for what happened to factor V. It's just a cofactor. Okay, but protein S does a little bit more than that. It binds to negatively charged phospholipids. It binds to negatively charged phospholipids, and this property allows the protein S to function in the removal of cells which are undergoing apoptosis. So cells that are undergoing apoptosis, the programmed cell death, protein S helps to get rid of these cells in a clean manner. It helps facilitate the removal of these dying cells in a clean way. Okay, so cells which are apoptotic no longer manage the distribution of phospholipids in their outer membrane. These cells are dying, therefore, the phospholipids within these cells will start to leak out. And these phospholipids are negatively charged and are recognized by the macrophages. So the dying cells will leak out phospholipids, the macrophages will recognize it and come down and swoop on those dying cells that are programmed to die. And what protein S does, it will bind to the negatively charged phospholipids that have leaked out of these apoptotic cells. And the protein S will form a bridge between the apoptotic cell and the macrophage. Okay, and the bridging property of this protein S will enhance phagocytosis of the apoptotic cell, allowing it to be removed cleanly without any symptoms of tissue damage, such as inflammation. So the protein S really helps with a dying cell cosmetically, okay, because the bridge that takes place between the phospholipids of a dying cell and the macrophages, it's facilitated cleanly by the protein S. So that's what protein S does. And that's the protein S and protein C lecture. Are there any questions? Okay.
I have one question for you. I'm sorry. Oh,
Sir.
my camera's off. Sorry. So I'm a little confused. One of the causes of purpura fulminans, was that DIC and sepsis, or did I
Yeah,
get that wrong?
it's a result of the pulmonary fulminans. So what happens is, let me go to that slide. The DIC in the babies, DIC in newborns. So you got your protein C deficiency and you got venous thrombosis and the habitual abortion, but protein C deficiency in the homozygous state can result in the DIC of newborns, and that is what causes the purpura fulminans. Okay, so the baby, the newborn, will get DIC, and to treat it, because hopefully you've done your prenatal screening and into protein C deficiency at birth, hopefully you can replace that defective or missing protein C, and hopefully the baby will not go into DIC and result in purpura fulminans. Okay, usually it's picked up in the prenatal screening, and they have laboratories, there's a certain window that you have to collect the specimen to get an accurate assessment of the status of the newborn. Okay, so if it has protein C, if it doesn't have protein C, but it's important to know, because if you have deficient protein C at birth, then you risk the possibility of having DIC. The baby has that risk. All right, does that answer your question?
Yes, thank you. Thank you.
All right, anybody else? Okay, so let's move on to vitamin K. All right. Excuse me for 1 second. Okay, vitamin K. Vitamin K made in the liver, 27910, vitamin K dependent factors. Okay, vitamin K is a fat soluble vitamin, and it's required for the maintenance of normal blood levels of the factors 2, 7, 9, and 10. Now, vitamin K is necessary for the carboxylation of specific glutamic acid residues. Okay, so the description of the carboxylation and gamma glutamic acid. What I say to you may seem a little confusing because it sounds like a lot of biochemistry, but the illustration later on in this lecture hopefully will clarify that. So vitamin K is needed for the carboxylation of glutamic acid residues in the post-protein synthesis of the vitamin K dependent factors. It serves as an essential cofactor for factors 2, 7, 9, 10. Those are your vitamin K dependent factors. And also for the anticoagulation protein C, S, and Z. We just talked about C and S. It's a cofactor. Vitamin K is a cofactor for carboxylase that catalyzes the carboxylation of glutamic acid residues on vitamin K dependent proteins. C, S, and Z must be modified by carboxylation to form gamma carboxyglutamic acid in order to become biologically active. And gamma carboxyglutamic acid residues enable the protein to bind to membrane surfaces. So that is very important, the gamma carboxyglutamic acid. Okay, so what happens is vitamin K is reduced, and again, this will all be described in the metabolic pathway of vitamin K in an upcoming slide, in the next slide actually. It's reduced to KH2 vitamin K. Oxygenation of the vitamin K becomes oxidized to drive the carboxylation reaction, that carboxylation reaction to gamma carboxyglutamic acid and vitamin K oxide. Okay, so it goes from the reduced form to the oxidized form. And the vitamin K oxide is then reduced back to vitamin K and it's ready to enter another cycle. So here we have vitamin K in the liver, made in the liver. A reductase enzyme will reduce this to vitamin K H2, the H2 meaning that it's reduced. Here you have glutamic acid. It's the target protein. Glutamic acid will combine with the reduced form of vitamin K and oxidize it to vitamin K oxide. But this, now the glutamic acid will now be converted to the gamma carboxyglutamic acid. So this is an important enzyme protein that's needed for other cell processes, the conversion of glutamic to gamma carboxyglutamic acid. Also, too, the reduced form of vitamin K now becomes the oxidized form of vitamin K. So you got vitamin K, reduced vitamin K by this reductase enzyme. So vitamin K, reduced vitamin K, back to oxidized vitamin K, okay? So this oxidized vitamin K is going to be further reduced again into regular vitamin K. It's this step here, the reduction of the vitamin K oxide, is where warfarin takes place. The action of warfarin takes place. Warfarin will block this step. So vitamin K oxide will not be converted to vitamin K. Okay, so warfarin will block vitamin K, therefore cause you to have as an anticoagulant. You will not form a clot. So it's a anticoagulant. Okay, vitamin K. This is the anticoagulant action. So vitamin K, you have your normal clotting. Without vitamin K, you will not have normal clotting. Okay, so this is where warfarin takes place. Remember, warfarin equals Coumadin, which is an anticoagulant. Okay, this is where this anticoagulant takes place. You will not form a clot. So no vitamin K, no clot. This is where warfarin takes place. So again, vitamin K via reductase will form a reduced form of vitamin K. Glutamic acid will oxidize the reduced form to form vitamin K oxide. And this glutamic acid will form gamma carboxyglutamic acid. So this vitamin K oxide has to return to vitamin K. If it doesn't return to vitamin K, then you're not going to get clotting. So this is where the anticoagulant will take place between vitamin K oxide and vitamin K. This reductase, this is where the block will take place. Okay, so that's the vitamin K metabolism. Vitamin K anticoagulants as warfarin block the reduction of vitamin K oxide to vitamin K. That's that last step. And it explains the antagonistic effects of warfarin on this cycle. So warfarin, also known as Coumadin, okay? Also known as Coumadin. Vitamin K is found a lot in our diets, especially leafy green vegetables. Remember that in vitamin B12, leafy green vegetables. So spinach, chard, cabbage, kale, broccoli, and Brussels sprouts all contain vitamin K. It's also found in fruits like avocado and kiwi fruit. And 2 tablespoons of parsley contain a ton of vitamin K, 153% of the recommended daily amount of vitamin K, if you like parsley. Average diets usually do not lack vitamin K. So vitamin K, like I said, is found in almost every meal that you consume. Vitamin K deficiency, therefore, is rare in healthy adults. Newborn infants are also at risk of vitamin K deficiency because their livers are not fully developed, because vitamin K is made in the liver. Vitamin K deficiency may be seen in individuals with liver damage. That's why if you know that a patient has like active hepatitis or liver cirrhosis, if you think about the liver, the source of your of vitamin K, you could have coagulopathies, okay? Because a lot of the factors, the coagulation factors, are made in the liver. If you have cystic fibrosis, inflammatory bowel disease, bulimia, and stringent diets, if you're not taking in vitamin K, you can have vitamin K deficiency, and anticoagulant therapy, i.e. warfarin or Coumadin. So if you're on Coumadin or warfarin, then that will affect, as I just illustrated, vitamin K oxide going to vitamin K. Drugs can also be associated with vitamin K deficiency. Salicylates, and salicylates would be, an example of salicylates would be aspirin. Aspirin is acetylsalicylic acid, so salicylates is aspirin. Barbiturates, or not tranquilizers, but antidepressants or tranquilizers, cefamandel, antibiotics. So there's certain drugs that can be associated with vitamin K deficiency. Doesn't discriminate between males and females. Both can have a vitamin K deficiency. The symptoms of vitamin K deficiency are heavy menstrual bleeding. Again, you know, it's like if you have a vitamin K deficiency, it's like an anticoagulant. So you'll have bleeding tendencies, you'll have anemia, you'll have bruising, and you'll have bleeding of your gums and nosebleeds. The liver makes bile acids and excretes them into the small intestine. And what one function of the liver is to play a critical role in the absorption of lipids. Okay, the absorption of lipids. That's why livers can have a tendency to be fatty. Okay, so vitamin K requires proper lipid absorption for its own absorption. So if you have liver disease, that will result in a decrease of bile salt synthesis, and it'll lead to impaired vitamin K absorption. So that's why if you have liver disease, you're not going to be able to absorb vitamin K. All right, the majority, and like I mentioned earlier, the majority of your clotting factors are made almost exclusively in the liver. So if you have liver problems, you're going to have clotting problems. You're going to have coagulation problems. Intestinal diseases result in lipid malabsorption in the small intestine, can also lead to defects in vitamin K absorption. In infants, you can have hemorrhagic disease or death or permanent brain damage. Vitamin K deficiency in infants is really, really not good. At birth, the liver essentially has no vitamin K reserves. That's why babies are at risk. Vitamin K is needed for the production in bone proteins. Okay, so if you don't have vitamin K, then you're not going to have good bone development, and therefore you're going to have a tendency to have fractured or reduced bone density. Patients using vitamin K antagonists show toxic effects on rapidly growing bone. Okay, so not having vitamin K can lead you to have bone problems. Rat poison, decon, rodenticides act by inducing a vitamin K deficiency. So since it induces a vitamin K deficiency, you're not going to form clots, therefore you're going to have bleeding tendencies. So the way decon or these rodenticides work is that they induce a vitamin K deficiency. If you have a vitamin K deficiency, then the rodents or the mice will eat this poison, and they will die by bleeding. Okay, so they're basically fed this decon that will induce vitamin K deficiency. Another story is like in Argentina. In Argentina is they have cattle as part of their agriculture. And what was going on is that the vampire bats were attacking the cattle industry in Argentina. So what happened, the way the farmers or the way they addressed the cattle as being attacked by the vampire bats was they fed coumadin. They fed coumadin to the cattle. And what happened was the vampire bats would suck the blood of the cattle, which now had coumadin. And when the bats would sleep, it caused a bleeding tendency. And when they would sleep, they would actually bleed out through their eyes. So that's what solved the vampire bat problem in Argentina. And the cattle industry was rejuvenated. Vitamin K has antioxidant properties. Okay, so levels of vitamin K is lower. They found out that patients who have the Alzheimer's disease gene, they had low levels of vitamin K. So if you increase the levels of vitamin K, hopefully that would, the thinking was that you would slow down or inhibit the development of Alzheimer's disease. Alzheimer's disease also inhibits cell death due to oxidation of nerve cells and has a positive effect on neuronal damage. So it has, it helps out, helps repair damage of nerve cells. Vitamin K can also be applied topically. Postoperative bruising from cosmetic surgery and injections. If you apply vitamin K, then it makes the wound from surgery heal very cleanly. It'll take care of broken capillaries and also aids in the hyperpigmentation and dark underneath the eye circles. Okay, so vitamin K has very significant cosmetic effects. And there was a study done on Japanese women with who had viral liver cirrhosis. So they gave vitamin K to these women, and 90% of them, it turned out, were less likely to develop liver cancer. So the vitamin K consumption helped prevent these women from developing liver cancer who had liver cirrhosis. Also, too, in Germany, there's an inverse relationship with vitamin K consumption and the development of prostate cancer. So the more vitamin K that they develop, decrease their chance of developing prostate cancer. So vitamin K has very positive effects on the body. And that's it for the vitamin K lecture. Are there any questions on that one? Okay, now for the third and final lecture of the year. The coagulopathies. Coagulopathies. Hopefully you're familiar with this page. All right, coagulopathies. Coagulation problems like factor deficiencies, etc. Okay, so in the coagulation laboratory, you perform screening tests. The most common ones are PT, PTT, fibrinogen. Those are real, and the CBC. You need to have CBC to make sure that you have an adequate platelet count. Okay, so CBC, PT, PTT, and fibrinogen. Not so much thrombin time, but it can be used, and bleeding time, which a test that is becoming antiquated. But PT, PTT are the two main coagulation tests. So when you run a PT and PTT, if you have, okay, so I know I didn't ask you to memorize the normal values for PT and PTT, but for pro time, usually, and it depends on different laboratories, depending on the type of reagent that you have. Remember, you have reagents that have a certain ISI and a standardized INR ratio. Well, because it varies from laboratory to laboratory, it depends on the reagents that you have, because ISIs from one reagent to another can be different. But generally, a normal pro time would be between 12 and 14 seconds. Okay, so use 12 and 14 seconds. And for a normal PTT, you can say between 20 and 22 seconds. All right, 20 and 22 for PTT. We'll just go by that. And 12 and 14 seconds for PT. So if you have an abnormal PT, meaning that an abnormal PT would be like, say you had a 19-second pro time with a normal PT, with a normal PTT, say it's 21. Okay, so if you have a 20 pro time and a normal PTT, so you have an abnormal pro time, what you want to do is you want to find out what's causing, knowing that the patient is not on any obviously with an abnormal proton, you would think he's on Coumadin. So the patient's not on Coumadin. So what's going on with this patient? Not on Coumadin, but he has an abnormal proton. What you do is you do a mixing study, a one-to-one mix. And what that one-to-one mix is, you take a certain volume, let's say 100 microliters of the patient's plasma plus 100 microliters of pooled normal plasma. So the rationale is you have plasma, patient's plasma. You're assuming that there may be a factor missing. Remember, no factor, no clot, right? So the patient has a prolonged prothrombin time, no factor, no clot. So you're thinking there's a factor deficiency. So what you do is you do a one-to-one mix with pooled normal plasma. The pooled normal plasma has all the factors present, okay? It has all the factors present. And when you do a one-to-one mix with the patient's plasma, suspected of possibly having a factor deficiency, you would hope that there would be correction. So you take your solution of the one-to-one mix and you retest it. If the pro time is corrected, then you can assume that the factor deficiency, that it's a factor 7 deficiency. Correction means that, remember I told you the normal pro time is about 12 to 14, right? And the patient's pro time straight was about 21. Well, if it corrected, if it came down to 16 or 17, that's correction. That means the factor 7 that was missing was present in the pooled normal plasma. So now you have what's called correction. So since it corrected, then you can reasonably assume that the patient has a factor 7 deficiency, okay, because there was correction. The pooled normal plasma replaced the factor that was missing. So the patient has a factor 7 deficiency, okay? Did you guys follow that with the mixing study and the one-to-one mix and the correction? Let me know if you didn't. I'll explain it again. Okay, so you have correction with the one-to-one mix with pooled normal plasma. If it didn't correct, so the patient's plasma, after you did a one-to-one mix with pooled normal plasma, remained elevated, like still 22, 24. When you ran it with the one-to-one mix with the pooled normal plasma, it should have corrected if it was a factor deficiency. But in this case, if it did not correct, then the problem was not a factor deficiency. You can attribute the problem being due to what's called an inhibitor to factor 2, 5, 7, or 10. So this kind of tests with the mixing studies and the one-to-one mix with pooled normal plasma. We did it in the laboratory that I trained at, but I think they concentrated that and left it for coagulation specialty laboratories to do the mixing studies. But if you do a one-to-one mix and it corrects, then it's a factor deficiency. If it does not correct, then you assume that there's an inhibitor present. Okay, that's the bottom line. You do a mixing study, if it corrects a factor deficiency, if it doesn't correct, it's an inhibitor. Okay, so in this example, you have a normal pro time with an abnormal PTT. You do the same thing. You take the patient's plasma, do a one-to-one mix with pooled normal plasma, and then you look for correction. If you do have correction, then you can reasonably assume that it's a deficiency in factors that were replaced by the pooled normal plasma, a deficiency in the factors of 8C, 9, 11, 12, prekallikrein, and or high molecular weight kininogen should be considered. I'm not going to ask you what the possibilities of the factor deficiency will be with a PTT correcting after a 1-to-1 mix. I'm not going to ask you that. Okay, just know that if you get correction, then that means you have a factor deficiency, because those missing factors right here have been replaced by the pooled normal plasma. If you did not get correction, then it's probably due to inhibitors to the factors 8C, 9, 11, 12, prekallikrein, and high molecular weight kininogen. So if it doesn't correct, you get inhibitors. Okay. Other inhibitors that can be a possibility are the lupus anticoagulant or the anticoagulant heparin. So you can have heparin as a contaminant can cause you to have a PTT elevation. The presence of heparin can be ruled out by the thrombin time. If the thrombin time is normal, the thrombin time is normal, then you have heparin present. Thrombin time will be, well, I'll take that back. The thrombin time will be abnormal in the presence of heparin. So thrombin time follows PTT. If the thrombin time is abnormal, then you have heparin. If the PTT is abnormal, then you have heparin. On the other hand, if you can do the reptilase time. If the reptilase time is normal, then you have heparin. If the reptilase time is abnormal, then it's not heparin. Okay. PTT will be abnormal in the presence of heparin. I hope you followed that. A normal reptilase means there's heparin, and abnormal PTT means heparin. Okay. So for specimens that have, it's in the same rationale goes for specimens that have both the PTT being abnormal and PTT being abnormal. You do your mixing studies with 1-1 mix with normal pooled plasma. If they do not correct, then consider inhibitors to factors 2, 5, and 10. If they do correct, then consider factor deficiency. So correction basically is meaning that you have a factor deficiency. Non-correction means you have the presence of an inhibitor, and that's how you can tell the difference between the two. All right, moving on to hemophilia A. Hemophilia A, you have prolonged PTT, normal PT, normal bleeding time. Mixing studies with normal or observed plasma will correct. So we would expect that it would correct because you have a factor deficiency. And the factor that we're concerned about is factor 8C. The most common inhibitor to a specific clotting factor is factor 8C. And this inhibitor is predominantly IgG and time and temperature dependent. When you have an inhibitor, the laboratory assay for inhibitor is the laboratory assay for inhibitor is the Bethesda assay, and inhibitors are measured in Bethesda units. So neutralization of 50% of the 8C activity is considered 1 Bethesda unit. So if you reduce the activity, then that's called 1 Bethesda unit. A reduction in activity by 50%, a reduction is 1 Bethesda unit. The lupus anticoagulants can be either IgG, IgM, IgA in nature, and they can be detected by these 3 tests. And again, you have to work in a coagulation specialty laboratory to be able to do these tests. The platelet neutralization procedure, the Russell-Viper venom time, and the hexagonal phospholipid APTT. So again, to distinguish factor deficiencies from factor inhibitors, and then considering the 50% normal, the Bethesda unit, the bottom line here is if you get correction, it's a factor deficiency, and if you get no correction, then you have an inhibitor. Going back to hemophilia A, that's called classic hemophilia. It's the most common of the hemophilic syndromes, and the hemophilic syndromes, which are A, B, and C. And the defect is the absence of the coagulant 8C. So A is 8C, and then B has a factor, and then C has a factor. Laboratory findings with hemophilia A is normal PT and prolonged PTT, normal bleeding time. If you see like a normal bleeding time or an abnormal bleeding time, if you have a normal bleeding time, then you can rest assured that you don't have a platelet problem. Bleeding time is a really, really very good indicator or if you have something going on with platelets, or if you have bloody gums, or if you have nosebleeds, those are platelet issues. Mixing studies correct with the APTT, obviously, because the factor 8C is the factor that's missing. Von Willebrand's disease and classic hemophilia A. Von Willebrand's disease is a recessive rather than is a autosomal recessive rather than sex-linked. It's consistent with prolonged bleeding times. And this is von Willebrand's disease now. So if you remember, if you have prolonged bleeding times, that means you have possibly a problem with your platelets. And von Willebrand's disease has mucocutaneous bleeding rather than hemarthrosis bleeding into the joint spaces. Mucocutaneous bleeding, again, mucocutaneous like gingival hypertrophy, bleeding in your gums or nosebleeds. Those are mucocutaneous bleeding. Again, those are seen with platelet problems. And deep vein hemorrhage. And that's not von Willebrand's disease. Remember, it's rather than hemarthrosis bleeding into the joint space than deep muscle hemorrhage. That's not von Willebrand's disease. So with von Willebrand's disease, the tests that you should run are bleeding time for platelets, platelet count from the CBC, a PTT. You want to do a mixing study to make sure that you have a factor deficiency, a factor 8C activity to nail down that it's a factor 8C deficiency. Von Willebrand factor antigen, ristocetin cofactor activity, ristocetin induced platelet aggregation, multiple analysis. Those tests below the APTT are usually done in the coag specialty laboratories, okay? But you can see based on the test that you probably have for von Willebrand's disease, an issue with platelets. Von Willebrand's disease was originally termed parahemophilia, and it's an inherited deficiency of von Willebrand factor. And von Willebrand's disease is the most common inherited bleeding disorder. So make sure you know that it's the most common inherited bleeding disorder, and it affects males and females equally. Von Willebrand's factor is a large multimeric glycoprotein. And remember, I talked about glycoprotein 2 and 3 and 1. Those are the glycoproteins that cause the platelets to be adhering to each other. That makes the platelet sticky. The von Willebrand factor is made within the megakaryocytes in the endothelial cells. So now we have definitely have a source of the problem, which is the megakaryocytes, which is the platelets and the endothelial cells. So circulating von Willebrand factor, what it does, it forms a complex with factor 8. So circulating in your blood, you have this complex, von Willebrand factor colon factor 8. The two of them go hand in hand, circulating around in your blood, the VWF colon 8. Okay, so a deficiency of factor 8 is found in hemophilia A. So hemophilia A is missing factor 8. Von Willebrand's factor is a carrier protein for factor 8 and protects factor 8 from proteolytic degradation. So at the site of injury, because those two are complex with each other, the von Willebrand's factor and the factor 8, the von Willebrand's factor will be nice enough to deliver the factor 8 to the site of injury. So remember, the two of them will be complex together, and then it will release, the von Willebrand factor will release the factor 8 whenever there's an injury that occurs. But the von Willebrand's factor will unload the factor 8 conveniently at the site of injury. Increased von Willebrand factor correlates to increased factor 8 because they go hand in hand. In von Willebrand's disease, the absence or dysfunction of von Willebrand's factor results in decrease in factor 8 and abnormal secondary hemostasis. So von Willebrand's factor is stored and secreted from the granules within the endothelial cells, known as ribopalade bodies. Okay, that's where von Willebrand's factor is stored. It's stored in the endothelial cells known as ribopalade bodies, and also too from the alpha granules and platelets. So the von Willebrand's factors is found in two places: the endothelial cells within the known as ribopalade bodies, and also two in the alpha granules. Remember, the alpha granules is the most numerous granules in platelets. So two places where von Willebrand's factor is found. 1 to 2% of von Willebrand's factor functions as a clotting factor, designated as factor 8C. Okay, so factor 8C is also known as the anti-hemolytic factor, AHF. And defects and deficiencies in factor 8C and von Willebrand's factor will result in, for factor 8C deficiency, will result in hemophilia A, and for von Willebrand's factor will result in von Willebrand's disease. Elevated 8C may cause hypercoagulability. Remember, if you have excess of a factor, like for example, elevated 8C, can result in hypercoagulability. So if you have hypercoagulability, then you'll have an increased tendency to form a clot. You'll form a clot with regular 8, but if you have excess or elevated amount of factor 8, then that can cause you to have hypercoagulability. And the problem with that is they have excess clot or a lot of clot that can result in pulmonary embolism, DVT, or stroke. Okay, so excess 8 is good, but excess 8 is too much. It's not good. Oral contraceptives and estrogen replacement therapy may also elevate factor 8C and von Willebrand's factor. That's why if you're on oral contraceptives, you also may have a possibility or risk of having PE, DVT, or stroke. So your doctor should be monitoring if you're being placed on oral contraceptives or hormone therapy, estrogen replacement. Hemophilia B, that's factor 9. So hemophilia A is factor 8. Hemophilia B is factor 9, or Christmas disease, not because of the season, but it's named after a little boy whose last name was Christmas. It's a sex-linked bleeding disorder. It's rare in females. In severe hemophilia B, total absence of factor 9. So hemophilia B is factor 9. One complication of hemophilia A and hemophilia B is the development of antibodies and inhibitors. The problem with these antibodies, they could be autoantibodies. Okay, so some autoantibodies can also, as I'll talk about later on in this lecture, can also attack your platelets, where you can have a low platelet count. So the tests to diagnose hemophilia B are normal pro-time, normal thrombin time, normal bleeding time, prolonged PTT, because now you have a decrease in factor 9. So factor 9 is in the intrinsic pathway, so you have a prolonged PTT, and it corrects with, and you would expect it to correct with pooled normal plasma because it's a factor deficiency. Inhibitors will cause non-correction if they're present. And finally, hemophilia C. Hemophilia C is 11. So hemophilia A is 8, hemophilia B is 9, and hemophilia C is 11. Another name for hemophilia C is the Rosenthal syndrome, and it's predominantly found in the Ashkenazi Jews. I think the Ashkenazi Jews is a population of Jews that are found in Eastern Europe, and it's an inherited autosomal recessive disease. And the deficiency leads to a bleeding disorder. Deficiency of factor 11. Hemophilia C is factor 11. And the symptoms include your typical bleeding problems: bruising, nosebleed, menorrhagia, hematuria, blood in the urine, prolonged or delayed postpartum bleeding, bleeding from dental extractions, bloody gums, the gingival hypertrophy. So you have bleeding problems. Replacement therapy is not needed unless surgery is required by the patient. Your laboratory results are normal PT, thrombin time, bleeding time, but since it's 11, you can have intrinsic factor, therefore you have a prolonged PTT, and it will correct with mixing studies, as you would expect, because it's factor 11 that's missing. All right, platelets. Platelet storage pool defect. This is a type of coagulopathy characterized by defects in the granules of platelets. So you have normal platelets. You can have a normal platelet count, but the platelets are not functional because the granules are defective. Particularly, there's a lack of granular non-metabolic ADP in these platelets. The patients with ADP deficient storage pool disease will present as a prolonged bleeding time. So you'll have a normal platelet count, but your bleeding time will be abnormal. Normal bleeding time is 0 to 3 minutes. So a prolonged bleeding time could be like 9, 10, 13 minutes. So remember, the bleeding time test is to give you an indication of platelet function. So you can have a normal platelet count, but your platelets will not be functioning correctly. The bleeding time test will tell you that you have improperly functioning platelets. In platelet storage pool defect, it may involve the alpha and the dense granules. The next syndrome is called gray platelet syndrome. It's called platelet alpha granule deficiency. So remember, alpha granules were the most numerous granules. So the reason why they call it gray platelet syndrome is because these alpha granules have either reduced or absent granules in the platelets. They look like they're empty, and that's why they're called gray platelet syndrome. They're just empty, that you can't see the granules. And it's characterized by a very low platelet count with abnormally large platelets. So a low platelet count with large platelets is found in the gray platelet syndrome. And the defect is in the bone marrow. It's a failure of the megakaryocyte to package the secretory proteins into the alpha granules. Okay, the secretory proteins are not packaged in the alpha granules. And then finally, deficient platelet production, congenital disorder associated with decreased platelet production. And there's 4 of them. There's 4 deficient platelet production disorders. The first one is Chidiac-Higashi. The next one is Hermansky-Pudlak syndrome, May-Hegland anomaly, and Wiskott-Aldrich syndrome. Okay, so each of these 4, I'm going to give you characteristics, but I'm going to focus on the characteristics I want you to know, okay? So the first one is Chidiac-Higashi. And with Chidiac-Higashi syndrome, these patients are oculocutaneous albinism. So these are your albinos. They have white skin and pink eyes. These are your albinos, oculocutaneous albinism, okay? And the other characteristic is that they have Dolly bodies in their neutrophils. You remember Dolly bodies? Those are the blue blotches in the neutrophils. So oculocutaneous albinism with Dolly bodies is the Chidiac-Higashi syndrome. Okay, so you'll have a prolonged bleeding time, obviously, or you would expect that because it's a platelet problem, and it's a storage pool defect of platelet storage granules. So the 2 main characteristics of Chidiac-Higashi are the oculocutaneous albinism, the white skin and the pink eyes, and the presence of Dolly bodies. The next one is Hermansky-Pudlak syndrome. Here, again, you have oculocutaneous albinism. So don't confuse that with Chidiac-Higashi, because the other characteristic I want you to know about in Hermansky-Pudlak syndrome is the ceroid lipofuscin. So in Hermansky-Pudlak syndrome, you have the development, accumulation of ceroid lipofuscin. And this ceroid lipofuscin is a wax-like substance that accumulates in the lungs. So the patients with this syndrome have trouble breathing, and you can get fatal pulmonary fibrosis. So bleeding problems due to platelet storage pool defect, you would expect that because it's a platelet problem. And you have the accumulation of ceroid lipofuscin. So the 2 characteristics of Hermansky-Pudlak syndrome are the oculocutaneous albinism and the ceroid lipofuscin. Okay, so Chidiac-Higashi is acute cutaneous albinism, and the presence of Dolly bodies. The presence of Dolly bodies, acute cutaneous and Dolly bodies. This is acute cutaneous and ceroid lipofuscin. In May-Hegland anomaly, you have the accumulation of just Dolly bodies, oculocutaneous syndrome, okay? You just have Dolly bodies with giant platelets. That's May-Hegland. So if you see, and it's common to see, I shouldn't say common, but if you come across in your differentials, you see Dolly bodies, don't say, wow, that's May-Hegland. Usually the Dolly bodies are pretty large, and then you'll notice giant platelets. But this is one of the easier ones to identify. You won't know that, you obviously won't know if the patient's is suffering from albinism. But if you see Dolly bodies and giant platelets, then you have May-Hegland. So Chidiac Higashi to review is oculocutaneous albinism with Dolly bodies. Herman Polanski is oculocutaneous albinism with ceroid fusion. And then May-Hegland is Dolly bodies with giant platelets. Okay, hopefully you followed that one. And finally, with the Wiskott-Aldrich syndrome, you have eczema, so you can have skin problems and immunodeficiency, dense granules, pyogenic infection. But the characteristic I want you to know is that you have thrombocytopenia resulting in petechiae. Remember petechiae from previous lecture? Those are those pink blotches from the tourniquet test. If you have petechiae and bruising, that's a characteristic of the Wiskott-Aldrich syndrome. The platelets are small and dysfunctional. You get nosebleeds and bloody diarrhea, and this one's mainly found in males. But the characteristic of the Wiskott-Aldrich syndrome is the presence of petechiae. So you have oculocutaneous and Dolly bodies. You have oculocutaneous and ceroid fusion. You have giant platelets with Dolly bodies, and then you have petechiae with bruising. So now you can associate those findings with a certain disorder. All right, idiopathic thrombocytopenia purpura, and that translates into I don't know why my platelets are low and causing bruising. Okay, idiopathic, as you recall, the doctor doesn't know what causes it. You have low platelet count, and purpura means you have bruising. So this is the ITP. This is ITP, idiopathic thrombocytopenia purpura. And it's one of the most common disorders causing isolated thrombocytopenia. And as I mentioned earlier, with the development antibodies or autoantibodies, your platelet count can be low due to antibodies that are developed, and it's just chomping on your platelet count. So that's why you have a thrombocytopenia. That's why you have thrombocytopenia. And usually it's diagnosed by exclusion. You do a lot of tests and you can't determine anything from all the tests that you do. So it's usually diagnosed by exclusion, which is not really a good way to diagnose a disease. ITP is found in children, both children and adults. Heparin, HIT. HIT is heparin-induced thrombocytopenia. So if you're an inpatient and you're on heparin therapy, usually if you're in the ICU for an extended period of time, usually in the ICU, they'll put you in a HepLock and you'll be on heparin therapy. Well, extensive heparin therapy can cause you to have thrombocytopenia. It can affect your platelet count. And it's caused by the formation of abnormal antibodies that activate platelets. And the thrombocytopenia usually is not that critically low, but it will just cause a decrease, a reduction of your platelet count. Okay, and that's the HIT, heparin-induced thrombocytopenia. And the platelet count usually falls 5 to 2 weeks after heparin is first given. So you can be in the ICU for an extensive period of time after your discharge, and they run a CBC after your discharge. They'll notice that your platelet count is a little bit decreased. That reduction is probably because of the heparin therapy. The most common symptom is enlargement or extension of previously diagnosed blood clot. Okay. Extension of previously diagnosed blood clot. And finally, factor 13 deficiency. Factor 13 deficiency, as you recall from the coagulation cascade, coming off of thrombin on the left side, it's fibrinogen going to fibrin, and on the right side, it's 13 going to 13A. Okay, so in factor 13 deficiency, you have recurrent bleeding that's taking place 12 to 36 hours post-trauma. So you're in a trauma situation, they close up your wound, they think that you've stopped the bleeding, but you continue to bleed 12 to 36 hours after they've applied dressing. You're still bleeding. And what's happening is that this is resulting from the dissolution of the soluble unstable fibrin clot. Okay, so you recall the white thrombus and the red thrombus. Well, the fibrin clot is not stable. And that's because you have a factor 13 deficiency. So remember, no factor, no clot, right? No factor, no clot. So here in this case, you're missing factor 13. The most common clinical symptom is bleeding from the umbilical cord stump. So a woman delivers her baby, and then normally her umbilical stump will heal itself. But what happens is days, maybe more than a week later, you're still your umbilical stump is still weeping, and it's not healing properly, and it's not developing a scar properly. So that's probably due to a factor 13 deficiency. A treatment for factor 13 deficiency is usually replacement with FFP, which is fresh frozen plasma, or cryoprecipitate. So these are blood products that contain clotting factors. FFP contains your clotting factors. More concentrated factors are in the cryoprecipitate. Okay. Laboratory findings with factor 3 deficiency is everything's going to be normal. Normal PT, normal PTT, normal fibrinogen, normal bleeding time, and normal platelet count. The only thing missing is factor 13. So to test for this deficiency is called the 5 molar urea test. So you take whole blood and you draw it and you add 5 molar urea. Normally a clot will form, but if the clot does, and normally the clot will form and the clot will remain, but if it dissolves after 24 hours in this solution that contains 5 molar urea, if the clot dissolves in 24 hours, then you have a factor 13 deficiency. Okay, if the clot remains, then it's not factor 13. Okay, so here's the table. Here's the table. Factor deficiencies, and starting with fibrinogen 2, 5, 7. On the table on your test, this left column will be the same. So this will be present, and that's what it's going to look like on your test. So the left side and the top is going to be completely the same. You're just going to fill in the normals and the abnormals. So if you start with the first column, and I'm going to show you how to memorize this, and unless you've already memorized this, but anyway, you got abnormal 1, abnormal, so abnormal 1, abnormal 2, then abnormal, and then the rest are normal. So abnormal 1, abnormal 2, meaning the 1 meaning 1 normal, abnormal 2 normal, then another abnormal, and then the rest are normal. Okay, that's for the bleeding time, the first column. The second one, just think 4, 3, and 1. 4 abnormal, you're starting off with the abnormals. 4 abnormals, 3 normals, and then 1 abnormal, then the rest are normal. So this one's 1 abnormal 1, 1 abnormal 2, 1 abnormal, and then the rest normal. Okay, so 1, then 2, then the rest abnormal, and then this is 4, 3, and 1. 4 abnormals, 3 normals, and then an abnormal, and then the rest are normal. On the third column, just think of 7 and 13. Everything's abnormal with the exception of 7 and 13. Everything else is abnormal. So you'll just have to memorize for the APTT 7 and 13. 7 and 13 deficiency is normal. And then the next 2 columns, thrombin time and fibrinogen, you start off with abnormal. and then the rest are normal. Start off with abnormal for fibrinogen, and the rest are normal. So these two columns are really easy. Then the last column is easy. The first one is non-applicable, but everything is normal, and you already know the 5-molar urea test, and that's for factor 13. So everything is normal except for factor 13. All right. So one abnormal, abnormal 1, abnormal 2, abnormal, and then the rest normal. 4, 3, and 1, 4 abnormal, 3 normal, 1 abnormal, then the rest normal. Then the PTT, 7 and 13 are normal, the rest are abnormal. The next two columns are easy, abnormal at the top, and everything's normal down below. And then the 5-molar urea, non-applicable at the top, and 5-molar urea, if you're paying attention to my lecture, is factor 13. That's the only one abnormal. Okay, so hopefully next week you'll be able to fill this out. Okay, do it a couple times. That's why I gave you a blank. Print it out a couple times. See if you can fill out based on what I just told you, or if you have your way of memorizing. Hopefully you'll do well on that test, on the test next week. All right, so that is it for my lectures, my last lecture of the year. So next thing I want to show you is okay. Next one I want to show you is this one. All right. The coagulation cascade. Okay, I sent this to you, and it's an updated version. Okay, so remember, when you're doing the coagulation cascade, you're not going to have this. It's basically going to be blank, and your word bank is going to be a bunch of numbers and some additional cofactors, which I included. PK for prekallikrein, K for kallikrein, and homework. Just think homework. Homework is high molecular weight kininogen. So remember, you start off 12, 11, 9, 10. 12, 11, 9, 10. That's how you start. Then it goes to 12A, then it goes to 11A, then it goes to 9A, 10A, and then 10 goes to 10A twice. So 10 will go to 10A, 10 will go to 10A. Because on this side, your extrinsic system, 7 will go to 7A. And then 12A will come down to catalyze this reaction. 11 will come down to catalyze this reaction. 9A will come down to catalyze this reaction. Okay, so those are the factors. The next thing are the cofactors. You got pre-K to K. Prekallikrein to kallikrein will catalyze the 12 going to 12A, and then the homework, 12A coming down. So PK to K is for 12 to 12A, and then homework is for 12A coming down. Okay, so the first two reactions have the prekallikrein, kallikrein, and the high molecular weight kininogen. And also too, the calciums. There are 6 locations for calciums. The 9 going to 9A. So 9 has a calcium, 9A has a calcium, and 7A has a calcium. Okay, so 9, 9A, and 7A. And then between the 9A and the 10A, 9A coming down, you have 8 going to 8A. And then for the 10A coming down, you have 5 going to 5A. Okay. And then for your calcium, your 10A coming down is calcium. So this is now your 4th calcium. So here you have in the common pathway 8 going to 8A, going to the 9A coming down, and 5 to the 5A for the 10A coming down. And then also 2 on the 10A coming down, it's calcium. This is your 4th calcium now. And then you have your prothrombin to thrombin. And that's your next slide. Prothrombin to thrombin. One common mistake is, whoops. Okay. One common mistake on this part of the pathway is that the arrow coming down from thrombin, people will make it the arrow coming down from this reaction. That's not the way it goes. It comes down from thrombin because thrombin will catalyze the 13 going to 13A, and thrombin will catalyze fibrinogen going to fibrin monomer. Okay. So remember when I talked about the APC and the thrombin with the thrombomodulin. That's why if you take out this thrombin, then you're going to have a anticoagulant reaction. So thrombin comes down and catalyzes 13 to 13A. Again, branching from the thrombin will catalyze fibrinogen going to thrombin. And then your fifth calcium, because you have 1, 2, 3, 4, and your fifth calcium is at the 13 going to 13A. This is your fifth calcium now. Okay. And then finally focusing on the fibrinogen going to fibrin monomer. Fibrin monomer going to the fibrin clot. The 13A from the 13 going to 13A, the 13A will catalyze this reaction here. So the arrow will go here, and then your 6 calcium will be right there. So remember, 6 calciums. So what you'll be expected to do is you have all these components in your word bank. All right, you'll have all the components in your word bank. You're just going to need to organize it all together. Okay, 12, 11, 9, 10 coming down, and then from the 10A, you're gonna put your 8 to 8A and then 5 to 5A, and then from the 10A you're gonna go prothrombin to thrombin, and then from the thrombin you're gonna branch from the thrombin. Remember to branch from the thrombin. The reaction fibrinogen to fibrin monomer, and a 13 to go 13A. Make sure you put your calcium, and then from fibrin monomer going to your fibrin clot, that's where your final calcium is. So hopefully you'll put all these components together into one cascade. And you know, if I was in the laboratory and I have it on the board, I can put it all at once. But on PowerPoint, I'm only limited to these slides. Hopefully, when you practice doing them, that you can put them all together. Okay. So remember, from the 10 coming down goes prothrombin to thrombin, and then the branching from the thrombin to the 13, 13A, and the fibrinogen going to fibrin monomer, and then the fibrin monomer going down to the fibrin clot. Okay, there it is right there. And then I went over this. Abnormal 1, abnormal 2, abnormal, all normal. 4, 3, 1, abnormal, 3 normals, and 1 abnormal, and then the rest normal. The next one is 7 and 13 are the only normal ones, and everything else is abnormal. These two are all normal with the exception of the first two. Everything across the top is abnormal with the exception of 5 molar urea. So these two columns, everything's normal with the exception of the top. And with 5 molar urea, you're looking for a factor 13 deficiency, and there it is right there. So play with this blank form a lot for, let me see. And then also too, fibrinolysis. Make sure you start, this is also going to be a blank sheet of paper, and then you have your word bank. So make sure you start with plasminogen, you're going to plasmin, and going to the scissors, fibrin gets chopped into fibrin degradation products. Okay, so that's your main fibrinolysis. This is your main fibrinolysis right there. It's going to be your job to put your activators, your TPA, your urokinase as an activator, and your factor 11A, 12A, and kallikrein as an activator acting on this reaction here. And then your inhibitors is plasminogen activator inhibitor 1 and 2. That's going to be in your word bank. Make sure you know where it goes. And then your alpha 2s. Your alpha 2, remember, that's the fast acting inhibitor, and then your alpha 2 macroglobulin. That's acting, these are your inhibitors acting on plasma. Your activators act on plasminogen going to plasmin, and then your inhibitor, the alpha 2s act on plasmin, and this inhibitor acts on TPA and urokinase. The urokinase can be urokinase slash streptokinase. And then your thrombin going to thrombin going to fibrin, and fibrin going to fibrin degradation products, and then thrombin going to thrombin activatable fibrinolysis inhibitor. This is an inhibitor. See, there's a red arrow here. So you have 1, 2, 3, 4 inhibitors, and you have 3 activators. Okay, so but I listed them out in a handout that I emailed to you earlier. It's a listing of the activators, inhibitors. Make sure you indicate that on your answer sheet. So those are your main diagrams: the chart, the factor deficiency chart, your fibrinolysis pathway, and then your coagulation cascade. I was going to do the vitamin K, but I'm not going to do that. I'll be nice to you, not do the vitamin K metabolism. All right. Are there any questions? So make sure you know this by heart. Make sure you can reproduce this. And make sure you can reproduce the coagulation cascade, that you can put all these together into one cascade. That looks like this, but not the Roman numerals. Again, I don't care for the Roman numerals. And make sure you can fill out this table. And I show you how I would memorize it: the 1, 2, and then a 4, 3, and 1, and then the 7, 13, and then all negative, all normal, and then here's 13. So hopefully you can complete those tables. A lot of points at stake. A lot of points are at stake with these three pathways. Okay, so if you're borderline on B going to A, it would behoove you to score your points on these tables because, like I said, a lot of points are at stake. Also, too, with respect to your grade, if obviously anything in the 90s is going to be an A, but and then if you're in the 80s, one thing that I will consider is that if you've shown improvement, then you probably would deserve the higher grade. So I look for trends like that, is that if you show a trend in improvement and you didn't hit a score that ended up in the 90s, what I take into consideration is your effort getting stronger towards the end of the semester. So I'll take that into consideration. So do well on your quizzes. You have 2 quizzes and the matching quiz. So the matching quiz exam tomorrow is, you'll have an exam 5. Exam 5 will consist of your matching and multiple choice. So tomorrow you'll get exam 5, and exam 5 will consist of terminology that you'll have to match. You'll be given terms and match it with a definition. The next section will be alternate names. So factor 1, factor 2, like for example, factor 4 is calcium, okay? Things like that. Make sure and I've given to you in that coagulation reviewer I gave last week, make sure you know the alternate names, okay? Make sure you know the alternate names. That's the second section of the matching quiz. And then the third one is basically inhibitor versus activator. So I'm going to give you components of the fibrinolytic pathway, and I'm going to list the components, and you tell me if it's an activator or if it's an inhibitor. So only 3 sections on the matching portion. Again, score as many points as you can. And I just told you what to study and what to expect. Okay, so that's the matching portion. And then again, the next thing is I'm going to review you for the multiple choice portion of exam 5. You'll be getting that. So next week, you'll be getting the pathways in this table. You'll be getting the pathways in this table. Okay. The pathways again will be blank. The table that you get will also be blank. You just fill in the table. You just fill in the pathways with the word banks, and that'll be that portion of the exam. And then for the multiple choice portion of the exam, I will send you the reviewer of the things I want you to know. Okay. And then for tomorrow's quiz, let me make myself invisible here for the moment. Okay. So quiz 19, what I want you guys to know. So tomorrow it's going to be quiz 19 and quiz 20. And then quiz 19 and quiz 20, and then 21 through 25 will be given not as a quiz, but it'll be part of your actually your multiple choice quiz exam will be comprehensive to the beginning of coagulation. So make sure, and then on your questions for on these quizzes, I use numerals that are not Roman numeral. So make sure you know your vitamin K dependent factors, you know, the 2, 7, 9, 10. Factor 7, you all know what that pathway belongs to, factor 7, right? Let me see. Anticoagulant therapy, outpatient versus inpatient. You know which one is the outpatient anticoagulant? Anybody can tell me?
Coumadin?
Yeah, that's Coumadin and heparin.
Professor Badgett, well, I got your attention. I believe we took quizzes 19 and 20 last time we were in session with Xavier.
Yeah, you know what? See, he didn't give me the quiz. He didn't give me the quizzes back, so I wasn't sure. So you've already taken this before then, right?
Yes, sir.
You don't want to take them again, right? No, you don't. Yeah, you do, but you're not going to get it again. Shoot. 1920. So 21 and 22. So you should be getting quizzes 21 and 22. All
Or
right.
an early Christmas miracle.
Ho ho humbug. Is that how it goes? All right. Quizzes 21, 21 and 22. 21 and 22. Here we go. You're going to be getting quizzes 21 and 22. Boy, Rudy, you spoiled it for everybody. You would have gotten 19 and 20 all over again. That's okay.
Man, I feel terrible now, you know?
Hey, believe me, you'll score points for honesty. 19 and 20.
But does everybody get those points also?
Oh, thanks, really.
All right. You know what was interesting is last semester, I had given, so quiz 21 is fibrinolysis quiz, and quiz 22 is the platelet quiz. What I thought was interesting is that I gave the fibrinolysis quiz as a take-home quiz. But we'll go over it.
Well, don't let us hold you back from that generosity.
Pardon me?
I said, don't let us hold you back from that generosity.
Well, I don't know. You tell me. Do you want 21 and 22? Because you had 23, 24, and 25. Basically, your exam 5 is going to be comprehensive from the beginning of COAG to today's lecture. It's going to be comprehensive and it's going to be in class. So I can throw in take home for 21 and 22. What do you guys say?
Yes.
The take-home exam, that one.
Take home. I like
Take-home
that.
exam.
Some people are shy. They don't want to say, well, you guys can take your in class. So speak up, tell me what you want. Take home.
Take
home.
All right.
Take home.
All right. Okay. So after this lecture, I will send you quiz 21 and 22 as a take home. So email it back to me as soon as you can, hopefully sometime tonight, or definitely before tomorrow. Okay, definitely before tomorrow. So 21 and 22 will both be take home. And then next Thursday, you're going to get exam 5. So I'm not going to give anything to Xavier on tomorrow because your exam is going to be take home. Actually, yeah, it's going to be take home and you're going to email it back to me. So you're not going to give it to him. So you're not gonna, oh wait, but then again, the matching. So the only thing you'll take in class tomorrow is the matching, right? You guys can handle the matching. Basically, it's gonna be 5 terms, 5 definitions. Hopefully you guys could be able to do that. And then it's gonna be alternate names of the factors. I gave you guys a reviewer for those. Didn't I give that as a reviewer to you last time? You know, like what's the alternate name for factor 9 or 11 or 13? Fibrin stabilizing clot, that's factor 13, right? Make sure you know those, okay? And I gave those to you. So that's basically a memorization of alternate names. And then the final one should be really easy, because tell me which one's an activator and tell me which one is an inhibitor. And you know what? I will be sorely disappointed if you guys do not do well on especially on that portion. The matching should be, because you guys do well on matching anyway. All right. You guys do well on matching. So in class tomorrow, you'll just be getting the matching exam portion of exam 5. I'll send over the 2 quizzes and email it back to me, hopefully tonight or definitely before tomorrow, by tomorrow. And then next week I'll give you the reviewer, or before this weekend, I'm going to try to give you the reviewer for the multiple choice portion of exam 5. And I'm telling you, I think most of you should score pretty well on the 2 pathways, the fibrinolytic pathway and the coagulation cascade. Okay, I mapped it out for you pretty well. Just put all those PowerPoint slides onto one pathway and you'll do fine. Just remember, from thrombin, the branching off from thrombin, not from prothrombin to thrombin line. It has, the branching off has to come from thrombin, because it seems like, I don't know why, but it seems like in previous classes they want to branch off from the line prothrombin to thrombin. Make sure you branch off from thrombin. And I'm going to make sure I see who's listening to me right now. Make sure you branch off from thrombin. And 6 calciums, and over they go. Remember, 8 going to 8A comes off a 9, 5 going to 5A comes off a 10. Pre-kallikrein to kallikrein is in a 12. Homework comes from 12A, okay? Remember that. Piece of cake. Any questions? No? Sure, no last minute questions? All right. You should all thank Rudy for pushing for take home.
Thanks, Rudy.
Okay. If not, I won't see you again until next year. So good luck on your quizzes and matching exam tomorrow, on your multiple choice exam next week. And make sure you know the pathways, especially that table. Like I said, a lot of points at stake. All right. So good luck on your exams and quizzes, and I will see you next semester. All right. So you guys take care.
Thanks for everything. Bye.
Thank you so much, Professor.
Thank
Oh,
you.
you're
Bye.
welcome.
you.
Anytime.
Bye.
Good night.
All right. Bye-bye.